Now is to talk about tinnitus. Tinnitus, which is, let's say, noise in the ears, is the best description of this. There are different types of tinnitus. There is the tinnitus that is like a sound like e in the ears, and this is the subjective, usually tinnitus. And there is the objective tinnitus, which the sound comes from something that is real and not just the perception of the patient. For example, like blood vessels, blood that hums near the ear can cause pulsatile tinnitus, which is a tinnitus that is like humming with the pulse. So it's like, namely, the patient can hear their blood moving around their ears. There are different causes for this, starting with venous problems like venous sinus stenosis that can also be apparent in idiopathic intracranial hypertension, which is also called pseudotumor cerebri, PTC. There are arterial causes for pulsatile tinnitus like AVM and Gloom's tumor. There are other types of tinnitus like clicks from, for example, TMJ, that can cause clicks in the temporal mandibular joint, like in uh, disc derangement with reduction of the temporal mandibular joint, which could cause clicks. There are sometimes clicks from the stapedius and the incus muscles that can cause clicks from myoclonus. We'll see this. There is this code that I try to tell you now. Tensor tympani and stapedius and all this. Okay, so we want to differentiate between two types of tinnitus, the subjective and the objective. I try to explain you about them. The subjective is usually caused from something that does not exist. There is nothing near the ear that causes the T the patient can hear. It usually causes from something that causes hearing loss, for example, from sensory neural hearing loss, Meniere disease, acoustic schwannoma, or from getting old, and hearing loss from getting old is sensory neural and usually bilateral. It can also cause tinnitus. Mechanical things can also cause tinnitus, like Eustachian tube dysfunction and things that cause obstruction there. All of this can cause subjective tinnitus. There are many theories to why this hearing loss causes tinnitus. One of the theories, like phantom, like when when limb is taken off, there are phantom pain. Here, when the hearing is lost, the brain of the patient start to create potentials that cause a compensatory potential that cause the subjective tinnitus that only the patient can hear and the examiner can't hear. Now, the objective tinnitus, sometimes even the examiner can hear. Again, there are the pulsatile tinnitus, the tics from the temporal mandibular joint or from myoclonus. Those are real sounds that the patient can hear and sometimes even the examiner can hear. Okay, so we talked about pathophysiology, etiologies. Now, the etiologies are varied. There is a table, but the most common disorder that are those that involve sensory neural hearing loss, like acoustic trauma, sound-induced, presbycusis, which is aging-induced, which is usually bilateral, ototoxic drugs like aminoglycosides, cisplatin, chemotherapy, and things like this. Meniere disease, which is a disease. Meniere is the manifestation. Usually, the pathophysiology includes endolymph hydrops, and it causes attacks of vertigo, hearing loss, which is usually in the low frequencies, and vertigo, hearing loss, and tinnitus. The vertigo episode lasts for hours usually in many years, and then it subsides. It usually, in the pathophysiology idea, is that the endolymph gets swollen, more and more endolymph, it ruptures the membrane, then the endolymph and perilymph gets together, and this causes the dizziness, the vertigo, and slowly the patient or the ear uh, hears from this, and then again it returns to a normal state, and then again the endolymph starts to accumulate, and then again it ruptures, and again cause vertigo. So this is why there are attacks of vertigo in Meniere disease. And migraines, I don't have something to tell about migraine. Usually, I think maybe they mean vestibular migraine. I'm not sure. Also, don't forget causes, the important causes of the lesions, the tumors like acoustic schwannoma that can cause tinnitus and usually hearing loss. Conductive hearing loss may also cause tinnitus, so all the things that can cause conductive hearing loss, which you can see here, starting with cerumen, foreign body, otitis media, externa, barotrauma, Eustachian tube dysfunction, otosclerosis, all of this can also be associated with tinnitus. Temporomandibular joint can cause clicks usually, and objective tinnitus you see from blood going throughout AVMs, going throughout eye vascular tumors like globus tumor, going throughout turbulent flow like in, I don't know, jugular vein that cause, for example, sinus venous stenosis. It sounds okay. And here are the spasms that I say, but okay. Now, this is a table of the causes of tinnitus. There is the subjective tinnitus, we have the acoustic trauma, and you can see here what are the diagnostic approach and what are the suggestive findings. So in acoustic trauma, for example, acoustic history of occupational or recreational exposure, in audiogram usually acoustic trauma cause high frequency hearing loss, which is sensory neural hearing loss. So it should not be with a air and bone conduction difference. It's usually in the high frequencies, 4,000, 8,000, something like this. Uh, Okay, barotrauma, I don't know, from diving, again, audiogram, central nervous system tumors like vestibular schwannoma, which can cause tinnitus, which can cause sensory neural hearing loss, which can cause a reduction in discrimination ability. It's quite important for a patient with mild hearing loss, but the discrimination uh, threshold are low. For example, discrimination result is less than 80%, might have this lesion. There are also stroke, multiple sclerosis. Drugs we talk, it usually cause bilateral tinnitus because it causes bilateral sensory neural hearing loss. You can see here the drugs, loop diuretics, furosemide, aminoglycosid like, I don't know, neomycin, salicylic acid like aspirin, and the chemotherapy cisplatin. Eustachian tube dysfunction, which can be from anything that causes congestion like upper respiratory allergies, and in the tympanometry, Eustachian tube dysfunction can present with tympanometry type B, type C. Type B is when the fluids accumulate, type C when there is only negative pressure. So you can see in the tympanometria B that the graph is flat, and the tympanometria C that the peak pressure is in negative frequency, which is from the negative pressure that can Eustachian tube cause. Usually, Eustachian tubes start with causing negative pressure and then fluids accumulate. So it may start with tympanometry C and go to tympanometry B. Okay. So again, what caused the Eustachian tube dysfunction? The congestion from upper respiratory, the congestion from allergies, problem with ear cleaning from air travel, and etc. etc. Infections like otitis media, labyrinthitis, meningitis, neurosyphilis. For example, otitis media can cause fluid accumulation and can cause conductive hearing loss. So in the audiogram, you can see conductive hearing loss with air and bone conduction difference and hearing loss, usually in the lower frequency because it's a conductive hearing loss. Air and bone conduction difference because of its conductive hearing loss. Meniere's disease, you can see here that they are looking for the differential diagnosis, for example, for vestibular schwannoa with MRI, but audiogram can show the usually lower frequency hearing loss. The definition of Meniere are episodes of unilateral hearing loss, tinnitus, fullness in the ear, and severe vertigo. Uh, Low frequency hearing loss is what define it. But all in Meniere usually in attacks, so it comes and goes. The pathophysiology I tried to explain it. It's a little bit complicated, but the endolymph get uh, accumulates, rupture of membrane, endolymph perilymph gets one inside the other, dizziness, the membrane heals itself, the dizziness stops, and again the fluid of the endolymph may accumulate. There are treatment that try to fight the endolymph heat drops, for example, diuretics, but sometimes we need more invasive treatments like treating the endolymphatic sac and drain it, sometimes even destroying the inner ear with injections of ototoxic drugs or inhibiting the vestibular or the eighth cranial nerve but by just cutting him out. Okay, obstruction of ear canal can also cause tinnitus. You can see cerumen, foreign bodies, external otitis. All of these can cause conductive hearing loss, and hearing loss can cause tinnitus. So you can look for them as a cause of tinnitus. And all what I said till now is the subjective tinnitus. Usually, it's a tinnitus like T, presbycusis, aging, again, usually bilateral. Audiogram can identify this sensory neural hearing loss, usually with aging. Objective tinnitus. Now we are going for the humming tinnitus, for example, for pulsatile tinnitus, ticking tinnitus, something that is real that causes the ringing or the sounds in the ear. So pulsatile tinnitus comes with the pulse. You can hear the pulse. You can hear the blood moves with the pulse, or you can hear the ticks with the TMJ or myoclonus. So dural arteriovenous malformation can cause a pulsatile tinnitus if it's near the ear, the temporal bone, because it's a pulsatile, the blood pulsate there. Uh, we can sometimes hear a brute when you put the stethoscope behind the ear. Okay, and to identify it, usually there is need for something imaging that can see the arteries, for example, MRA, MR arterography. Myoclonus from the muscles, irregular clicking, possible neurological like multiple sclerosis. And you can look for the source of the clicks. In tympanometry is quite hard. The fluctuating impedance can cause fluctuating results in tympanometry. Turbulent flow can cause pulsatile tinnitus, venous hum. Sometimes you can do what is called a jugular venous pressure, and then when you are putting pressure on the jugular vein, the pulsatile tinnitus can stop, and this quite tell you that the patient may have a venous problem, like I don't know, sinus venous stenosis. So looking for a CT venography or CT angiography can help, CT venography especially. Vascular middle ear tumors like glomus tympanicum or glomus in the jugular vein, glomus jugulare. Sometimes in otoscopy, you can see the red of the glomus tumor, glomus tympanicum, behind the tympanic membrane. Maybe I will be able to show you this. Here it is. You can see behind the tympanic membrane, open image new tab, you can see behind the tympanic membrane something that is red. This is the tumor which develops under or behind the tympanic membrane. This is the glomus tympanicum. Okay, so you can look for it with a angiogram or something that can see the arteries or MRI. And okay, Sometimes even the mass is pulsatile. Okay, so what are the red flags? If there is a bruit, particular over the ear skull, we said that it can, for example, hint for AVM, neurological symptoms other than hearing loss, unilateral tinnitus. Unilateral tinnitus is important because things like schwannoma, acoustic schwannoma, vestibular schwannoma, can come with unilateral tinnitus, especially if there is hearing loss, difference in hearing loss, and reduced discrimination test. All of this hint for that there may be an cerebropontine angle tumor, namely acoustic schwannoma or vestibular schwannoma, and you can look for it in MRI or CT. And when a vestibular schwannoma, let's look at it. You can see it right over here. The vestibular schwannoma, it's right over here. Maybe I will show you another big and more beautiful image. Here you can see the vestibular schwannoma, the brainstem, the cerebellum, and in between the cerebropontine angle. There is the vestibular schwannoma right over there. Okay, here you can see it too. Okay, so testing in patients with unilateral tinnitus and hearing loss, do an gadolinium enhanced MRI, for example, to look for the vestibular schwannoma. If the tinnitus does not accompany normal hearing loss, so you may wait some time, but eventually also cause an MRI. Do an audiogram. Everyone with tinnitus should refer to comprehensive radiological evaluation to determine the present degree and type of hearing loss. We can look for tympanometry for hearing loss and try to see what in the differential diagnosis can cause it. For example, if there is a hearing loss and in the hearing audiogram we see a low frequency hearing loss with airborne conduction difference and tympanometry type, I don't know, B and C, maybe there is, I don't know, fluids from stacking tube dysfunction or chronic otitis media with effusion, something that cause obstruction. If we see a, I don't know, peak in hearing loss in 2000 hertz and tympanometry that is AS, and the hearing loss is bilateral with a airborne difference, there may be, for example, otosclerosis. If there is autophony, vertigo with loud noise, and again hearing loss, that may be. mm, yeah. So, and with pulsatile tinnitus, so the patient may have, for example, suprasemicircular canal dehiscence, and etc. etc. The audiogram tympanometry and discrimination test and SRT can help understand what is the underlying pathology, so it is important, and the imaging can help us rule out or rule in neurological lesions, uh, for example, multiple sclerosis with flare, acoustic schwannoma with MRI, otosclerosis with MRI, parasemicircular canal dehiscence with, again, MRI CT, otosclerosis, as said, with MRI, uh, maybe ossicular chain dehiscence with MRI. So you can understand that imaging can also play a very important role based on what you think and what is your differential diagnosis. So be aware, note, take anamnestic hints, do audiologic tests, and if there is a need, do imaging. And the treatment depends on the cause, of course. If the cause is can be treated for, I don't know, vestibular schwannoma or otosclerosis, vestibular schwannoma with taking off the tumor or radiotherapy, or otosclerosis with implants with the replacement of the stapedius, or I don't know, Meniere with its treatments, multiple sclerosis with its treatments, AVM with its treatment, embolization or taking it off, glomus tumor with its treatment, I don't know. So every cause if there is a treatment, it can be treated. Note that the patients with the hearing loss, sensory neural hearing loss by aging, prebicusis, can sometimes uh, not be cured, but reduction of their tinnitus, or even as I see here, relieves in about 50% of patients with hearing aids or treating correcting the hearing loss can help reduce the tinnitus. Sometimes background noise can help the patient sleep because tinnitus is usually get worse at night because it is more quiet. The background is more quiet, so the tinnitus can be heard louder. It can cause depression and anxiety in patients, so be aware. Sometimes they are given, I don't know, never mind. You can see here the idea in older patients that they can have significant hearing impairments, so tinnitus may be common from sensory neural hearing loss. So tinnitus may be common complaint in aging patient, old patients. So be aware. Okay, that's it. This is about tinnitus. Thanks for making me your professional edition. If there are any mistakes or correction, please correct me. And that's it. This was about tinnitus.